like to invite the speakers to the webinar to join me here, and I will make the introductions. Excellent. Starting with Dr. Stephen Lane, who is a practicing primary care physician and clinical informaticist with over 30 years experience advancing the capture, exchange, and optimal use of health data to improve the care of individuals and populations. Dr. Lane serves as the Chief Medical Officer at Health Gorilla, one of the Qualified Health Information Networks, or QHINs, implementing the new National Trusted Exchange Framework and Common Agreement, or TEFCA, as well as one of the Qualified Health Information Organizations, or QHIOs, supporting California's new data exchange framework. Next is Deanne McCullen, is the Deputy Director for the California Data Exchange Framework, or DXF, part of the Center for Data Insights and Innovations. Deanne joined the center in January 2023, but has been engaged with the Exchange Framework since her participation on the DXF advisory group dating back to September of 21. Devin McGraw is the Chief Regulatory and Privacy Officer for Citizen, a platform that enables patients to collect, manage, and share their complete health records. She previously served for nearly 3 years as HIPAA Policy and Enforcement Lead at OCR and Acting Chief Privacy Officer at ONC. And she currently serves on advisory boards and committees for both federal and California state interoperability efforts. Last but not least, Michael Marchand is the Director of Interoperability and Innovation at UC Davis Health, with 30+ years experience in healthcare technology, the last 20 of which are focused on interoperability and participating with a number of industry organizations between HIMSS, HL7, AAMC, AAMI, Care Quality, and EPIC.
Great. Thank you so much, Eugene. And really, this is a shared presentation. Each of us here brings a unique perspective to this discussion. I think many of us have been involved in the evolution of data sharing and what we call interoperability for many years. So we're here really to talk about kind of the next steps of evolution that are happening in this complex world of data exchange. I've been asked to talk a little bit about the Trusted Exchange Framework and Common Agreement, or TEFCA, that I and many others have been involved in advancing for a number of years. This came out of the 21st Century Cures Act, which was passed at the end of the Obama administration and then clarified in the ONC's Cures Act final rule. And a lot of work has gone into the design and implementation and now the launch and initial use of the new Trusted Exchange Framework. So it's a very exciting space. Let's go on to the next slide. So this describes the overall architecture of the TEFCA, where you've got participants who engage in exchange of data. All of these participants need to connect to the framework through what's called the Qualified Health Information Network, or QHIN. And then those QHINs manage the traffic. So people have referred to them as super nodes of the framework, and get the data from one place to another. One can be a direct participant in a QHIN, or one can be a sub-participant under a participant. It doesn't really matter. But the framework, really think of it as like a framework for banking exchange or a framework for telecom exchange, where any participant can exchange data with any other participant, and then most of all of this framework methodology should just fade into the background. The RCE, or Recognized Coordinating Entity, is a organization called the Sequoia Project, which is contracted with the ONC to supervise and oversee all of this, to develop the governance and bring the process forward. Next slide. So there are multiple components in the TEFCA. There are agreements, operating procedures, technical requirements. There's a whole process for onboarding the QHINs. There are metrics that are being collected and will be shared, and an extensive governing model. So a lot has gone in to trying to do this. Again, really building on the experience that we've had as a nation, standing up other health data exchange networks and frameworks over the years. This very much draws on the experiences and the learnings from those other efforts. Next slide. So as I said, TEFCA is live. We went live in December. There are 3 QHINs that are actively exchanging data today: Health Gorilla, Epic, and the Kanza network of HIEs. All these other folks, the Health Exchange Med Allies, Commonwealth No2, have been designated as QHINs or are in the process of going live. We are starting to see exchange happening amongst at least the 3 live QHINs. The initial exchange purposes include treatment, which is a well-established purpose of data exchange, but as well as individual access services, which are designed to support individuals being able to access and collect and utilize their information. As Devin mentioned, her company is one that focuses in that space. Health Gorilla also has been supporting that. So it's exciting times as we look at new use cases coming online under the auspices of the TEFCA. Next slide. So as I mentioned, there are 7 QHINs that have been designated. There are a couple more who've had their applications accepted that are in the sort of the final testing phases, and then another one that's been had their application reviewed. So there are a lot of folks interested in getting into this space. As I say, it's a long path from even being designated to going live, but we are anticipating over the course of this year seeing hopefully all of these QHINs come live, bringing their constituent members and starting to see increasing volumes of exchange. Next slide. So timeline, with this started, as I said, with the 21st Century Cures Act back in 2016. Go live again was just back in December. And now we are focusing on upgrading from the first iteration of TEFCA to what's going to be called version 2, which really builds on existing exchange, which is largely document-based exchange, mostly queries for documents. That are live today and highly utilized across multiple networks and frameworks, but really moving towards more of a support for the exchange of FHIR, or fast healthcare interoperability resources, which is really the new paradigm and standard for health data exchange. And that's really going to be the major focus of version 2 and probably future versions of the TEFCA as they roll out over the coming years. Next slide. So TEFCA, as I said, is really focusing on transition to this version 2, updating their documents for greater use of FHIR, looking to expand the use cases beyond treatment and individual access services, which have gone live with an initial focus on public health, healthcare operations, and then moving on to payment, government benefits determination, and now research has been identified as the next purpose of use that's going to be supported. Other changes that have been made have just been trying to streamline the process of flowing down the terms of participation so that everyone's on the same page as they onboard. And there's also going to be a change with version 2 of allowing entities to utilize multiple QHINs instead of the 1 QHIN per business entity, which is required in TEFCA version 1. Next slide. So this is kind of where we're headed. And again, I won't reiterate this, but we are looking at these additional exchange purposes going forward. Next slide. This gives you a sense of the components and how they stack up, starting with an applicable law that underpins all of this, the common agreement, as I've discussed, working up to the implementation SOPs that support the various exchange purposes. Next slide. This describes the roadmap that TEFCA has outlined to move towards FHIR. initially looking at point-to-point fire exchanges being facilitated by the trust and technical framework of TEFCA, and eventually moving towards end-to-end fire exchange, which is probably going to take us a few years to get to. Next slide. And there were a number of events at HIMSS that focused on this. A lot of these materials are available online. You can find those at the RCE site that's linked there. And the next slide. And there's also an extensive resource library that the Sequoia Project, the recognized coordinating entity, has made available, and new documents are posted there. We're anticipating new documents being posted a week from today, looking at version 2 of the Common Agreement. Next slide. I think that's it. Yeah. So that was just a quick overview of TEFCA. And now we'll talk through how that fits in and complements the data exchange framework that we've been building in California.
Thank you, Dr. Lane.
Hi, everyone. Sound check, right? Sound good?
Sound good.
We already had an intro to me, so let's move on. Thank you. So I work with CDII on the data exchange framework. I work with all of my co-panelists in as external stakeholders, some almost to a daily pace, and others like weekly and whatnot. So definitely appreciate the collaboration and NorCal HIMSS getting us together today to present. For some people, you might not be aware of the data exchange framework. That's something I'd love to hear, like if this is brand new to you, if it's not, if it's old news. You should hear a lot of similarities and parallels to TEFCA, but hopefully you also hear some differences between us through this hour. The vision for the data exchange framework, as we can all read, but it's a first ever single statewide data sharing agreement. So the framework established and created one data sharing agreement that we call DSA, and within the terms and conditions of that, it requires the secure and appropriate exchange of health and human services information. So what we call that HSSI, Health and Human Services Information, to enable providers to work together and improve an individual's health and well-being. And when we use the word providers there, it's providers of care. So the long-term end game for the data exchange framework is to include social services providers of care. Health plans fall under the providers, so it's a very large, casting quite a large net there. And you might also hear me say DXF, that stands for Data Exchange Framework. Next slide, please. What it hopes to do is to bring together all these puzzle pieces with whole person care and patient-centered, breaking down the silos of services provided so that maybe hopefully we can, for state of California providing services, say under CalAIM, under developmental services, under the elderly, that we're not asking the recipients of care, the individuals who are receiving the care, to fill out the same information all the time, to have to carry their information from one provider of care to another. So putting the puzzle pieces together so that it's a more connected system. And with that in mind, it should help improve outcomes for all. That is our goal. So what the framework is, it was established in law in July of 2021. So it's 5 years newer than TEFCA, where that was first established in 2016. And the law, which was in AB 133, just a subset of a large part of AB 133, was then codified in California Health and Safety Code 130290. And within that regulation, CDII under California Health and Human Services Agency was to establish the framework to include a data sharing agreement, common set of policies and procedures, and a strategy for digital identity. So all of these documents are available on our webpage, and I think there's a link to that at the end of the slide deck. Next slide, please. There are certain entities that are required to sign and participate in the data exchange framework. So that's one of the things that tends to surface as a slight difference between the data exchange framework and TEFCA. So these are lifted up from Health and Safety Code 130290. These are the organizations that are required to sign, and then even a portion of these are the ones that were required to have begun exchange as of January 31st, 2024. So as Dr. Lane told us, that TEFCA started the exchange, went live in December, and then the data exchange framework was only somewhere in the like 6 to 8 weeks after that, January 31st. For most of these organizations, there are some carve-outs that have until 2026. And a lot of the folks who are voluntary or encouraged to participate in the data exchange framework, they may also have the opportunity to begin exchange as late as January 31st, 2026. So there are certain entities that are required to sign, and they should be doing exchange under the data exchange framework presently. Next slide, please. So very quick guide, what is the data exchange framework and what is it not? It is focusing on the positive first. It is rules of the road. So it has the policies and procedures that are the rules of the road. At this point in time, we do not have the SOPs, the standard operating procedures. There are a lot of folks that work in the TEFCA space that request those of CDII and the data exchange framework. That's something that maybe we will put in flight, but right now we lean very much on our policies and procedures. It is guidance and requirements for how to share data, the Health and Social Services Information, HSSI, with other data exchange framework participants. So participants in the framework with a capital P are those organizations that have signed the data sharing agreement. And that can be those required ones that were on the previous slide, or any of the other organizations that have signed voluntarily. And it is statutory language that permits sharing between a covered entity and a non-covered entity. And there's more specificity about that bullet in our privacy standards and security safeguards policy and procedure. So again, everything really leans upon what is in our policies and procedures. They're essentially the roadmap of how exchange happens under the framework. What the framework is not, it is not a specific technology. So it is not a data lake, it's not a database, it's not a data warehouse, it's not a data hub or repository. So that's where there's a lot of value to that, like a network of networks and driving exchange, but it's also, there are some limitations. Some people would want to be able to go to one place and pull everything and share that way, but that is not what it is. Nor is it a specific technology, system, or platform. So it's the AB Health and Safety Code 130290 does clearly states that it can be somebody's choice of intermediary, which is someone who helps do the exchange. They can use a health information organization. They can use their own technology. They may use a national network or framework. So it is quite broad in what folks are allowed to use. It's not like from where I hail, the meaningful use days where it needed to be certified EHR technology. We had our guiding light back then, so this is a little bit more open to that, which is really just, I think, a symbol of the times of how much and how far along technology has come in the HIT space over the last decade. And it is also not a specific HIE, HIO, QHIN, QHIO, or any particular electronic health record or electronic medical record. And then there is a link to FAQs at the bottom of this slide. I'm sure Eugene will be sharing the slides with everyone or having it posted, and resources on our webpage as well. Next slide, please. Here's a comparison and some background information on understanding TEFCA and the data exchange framework. They're mutually reinforcing initiatives. That's really a key component of that. Pretty heavy slide, dense slide on the words here, so I'm not going to read it all, just picking out a few of the words that resonate to me. TEFCA aims to create a seamless and secure flow, and TEFCA lays a foundation. Whereas the states, not just California, but states should be leveraging TEFCA to help accelerate the work. So that is definitely with the pace that we are going. It's never fast enough, but it has been a pretty incredible pace over the last 2.5 years or so. So data exchange framework is working to help accelerate what TEFCA and the ONC have been working on for quite a while. And there's also the focus of tailoring to a state's particular needs and to be able to address state needs and like state spending on healthcare, and how can we make things more affordable? How can we deliver better outcomes and close the equity gaps that exist in a lot of what COVID really put a spotlight on. So there's definitely very specific state things that we can leverage for having a data exchange framework. They do both share a mutual commitment to enhanced interoperability. And remember that regardless of which network or technology parties happen to use. So that's where it's potentially a little bit more open than TEFCA, but I think TEFCA also does drive a lot of, like, the technology is out there, like the chart that from the RC that Dr. Lane had, the QHINs networks all together, and then the participants and sub-participants, very similar to the flow of how the exchange should be happening in the data exchange framework. Key component on the second solid bold bullet is the exchange of social services data. So in that HSSI is the health and social services information, and there's a reason why the data exchange framework lives under the House of California Health and Human Services Agency, of which the Center for Data Insights and Innovation is a center or an office within agency. That there is a lot of focus on the social services, connecting the clinical, and that realm that has had a lot of the HIT investments since the end of late era of the Obama administration and throughout. But now we're really pivoting and trying to connect the dots and catch the social services data in the exchange, all safe and secure and under privacy regulations and everything like that. We understand that TEFCA participation is voluntary, and as we had on the other slide, there are a lot of organizations within California that are required to participate in the data exchange framework. Next slide, please. There was a recent article in Health Affairs article with the collaboration between California Health and Human Services Agency's Marco Mijic and then ONC's Mickey Tripathi. So a great article in there. I do want to raise that in that article, there's some verbiage about that TEFCA enables one to be able to be compliant with the data exchange framework, and that means that it enables it so as to help one to be compliant with the data exchange framework. So TEFCA is an opportunity that entities can leverage, but it doesn't check a box. If similar to, and we get questions a lot of the time, if I use this EHR, if I'm on this national network, if I am a participant in TEFCA, am I done? Have I met my obligations with data exchange framework? A really simple operational administrative response that could be like, have you signed the data sharing agreement as a required signatory? They might say no, because I'm a participant under TEFCA, then you would not be compliant with data exchange framework. And that's a very basic elementary example as opposed to the details of technical and IT exchange. And then another thing that, as I mentioned earlier on another slide, is just making sure that we're knowing that our privacy standards and security safeguards policy and procedure does touch upon some of the details on covered entities and business associates. So want to make sure folks are always thinking of our policies and procedures here. Great article though, because it's recent, it's late February, and it's relatively short, it's 4 or 5 pages, something like that. So it's a good read. So recommend that if you have not seen that yet. And next slide. And if I'm running long, call me off, Eugene. A lot of what I want to focus here is the right-hand column, because that's my lane. Data exchange framework is coordinated by CalHHS's CDI. Participation is mandatory. Broad set of health and social service organizations, including providers, plans, skilled nursing facilities, clinical laboratories, public health state agencies. Those are both encouraged. So it is casting quite a big net. And we have a lot of data exchange where it requires requested exchange for treatment, payment, healthcare operations, and public health purposes as well. So again, these slides will be available if you want to be able to do the side-by-side comparison. And let's go to the next slide. Transactions must be sent via any health information. I've pretty much touched on that. I haven't said much about the QHIOs. They are qualified through CDII. Health Gorilla is one of our QHIOs. I pronounce it QHIOs so that there is a differentiation between the TEPCA QHINs because people do get easily confused and they are different. We are standing up our QHIO program and I work with the QHIOs often. And the QHIOs, building a network of networks and regional HIOs throughout the state of California are working together really well. There's some challenges but there's a lot more opportunities than anything. And then again, exchange for most participants began January 31st, and we have a lot of work ahead of us. So I will see if there's any other slides. I don't think there are. Maybe resource slides. I could be wrong. Yeah, so resources, where to go, get on our listserv, and let's see what Devin and Michael have to share with us today.
You know, my particular piece of this is really to drill down a little bit on one particular use case that is expressly recognized in both the TEPCA as well as the data exchange framework, and that is individual access by patients, access by data subjects. And why is this an important one to drill down on? Well, you know, if you were listening at all to the introduction, it's it is the raison d'etre for the company that I'm with, Citizen. We're a platform that helps patients gather their health information. So we clearly feel pretty strongly about this, but it's not just us in terms of who cares about this. What can patients do with their data if they have easier access to it? Many things. This is just a few examples. I went ahead and threw on a graphic that the Office of the National Coordinator put together some years ago. But you know, when people are sick, their need for their data is heightened in terms of finding additional opinions for their care, maybe seeing if they're eligible for a clinical trial, wanting to support clinical research to power discoveries for a disorder that they are dealing with or that a family member is dealing with, and for which there's not good standard of care therapies. Even if you're not sick, just being able to keep family members and caregivers informed of what's going on. You know, many of us, and I think they're still calling it the sandwich generation, caring for young children, but also caring for other adults in our families, like our parents. Care coordination, the patient can sometimes play an important role in making sure that information is going to all the places where it needs to go. Having a better understanding of your own care, you know, you only get a certain amount of time with a clinician. Being able to take a look after the fact at notes can be enormously helpful in refreshing your memory or helping you understand what's going on. And then, of course, care coordination, assuring smooth care transitions, probably very similar there. Next slide, please. I love this slide. It's starting to get a little bit dated, but not quite. You know, the picture on the left is what the world of access to data looked like for so many patients for so long, and still to some degree is the case. You went to a medical records office, you got a lot of paper, but where we're headed is the kind of easy access to important information about your health in the same way that so many of us organize our lives today on our phones, on laptops, on computers, on tablets, being able to get this information electronically and use it and move it to where it needs to go. Next slide, please. Okay, so let's start with TEPCA. So what does TEPCA say about individual access? It's otherwise known as IAS, or Individual Access Services. And the common agreement, which is the baseline agreement that the kind of nodes on the TEFCA network. The QHINs are required to sign, but there are flow down provisions that each of those nodes on the networks are required to pass down to their participants and sub-participants. And there is a definition of individual access, which includes a patient might do this on her own, not acting with technology, or a patient may choose an app like Citizen, like Picnic Health, like Apple, and any number of tools that are out there today that patients can utilize to get access to their data. Now, this is interesting, I think. QHINs are not required to affirmatively offer individual access services, but they are required to respond, although there are some exceptions to this. What are some of those exceptions? Well, if the patient doesn't have the right to this data under HIPAA, there are some exceptions to the HIPAA right of access, then there isn't a required response to that patient's request under the common agreement. And then there's also this ability for the endpoints, the data holders, the original data sources, to be able to kind of set their own policies around when a match has occurred in response to a query. So let's say someone sends a query for Devin McGraw's record, and there's more than one Devin McGraw. And so they can't match the record, and so there's no return of data. That would not be a violation of the common agreement because the local match rules were not met. And that's just one example of how that could work. There are protections actually for patients choosing apps. And this is, I think, a very interesting aspect of the common agreement. The applications that are connecting in to the TEFCA in order to facilitate access for their individual users actually have to contractually agree to comply with most of HIPAA's privacy and security and breach notification rule provisions. These are entities that are probably not, in many cases, directly subject to those rules because those rules have limited applicability. But if they're going to participate in TEFCA, they have to contractually agree to do that. And in addition, most of them are also likely going to be subject to the Federal Trade Commission's breach notification requirements that apply to what are called personal health records. And for those of you who've been paying attention to this space, the Federal Trade Commission issued a proposed rule some months ago that would have greatly expanded the types of entities that are subject to their breach notification requirements as personal health records. There is also a provision in the common agreement that a patient or the app can be required to complete the entity's own form in order to request information. That could create some kludginess, I think, but I understand the reason why that's there. And that is because currently under HIPAA's right of access, if you go to an entity to request your information, that entity can actually make you use their form to complete that request and be able to get access to your data. Next slide, please. There is a technical SOP. This is, again, maybe one of the things that distinguishes TEFCA, one of many things that distinguishes TEFCA from the California Data Sharing Framework is that there are technical specs associated with TEFCA. You have to use an approved credential service provider. So these are sets of remote transactions, right? How does the entity who is processing a request for my records know that that request is coming from me? So you have to use a credentialing service provider that meets essentially has been approved to participate in TEFCA and that meets NIST identity assurance level 2 in terms of their processes for identity proofing patients online. And so you get verified upon your first request, and then you can make subsequent requests as long as your underlying credentials, like your state issued driver's license or your government issued passport, has not expired. In addition, the demographics that are submitted with that query have to themselves be verified. So, there is this verification process, again, that usually starts with the government issued ID. The data on that ID, it gets verified, but additional data that the patient might supplement, like, oh, I have a new address, if that's not verified through some sort of objective process that meets NIST level 2, that data cannot be used as part of the query. There are demographics that are required to be verified, and then some additional demographics that may be verified, but the response to a query is required to be only, I think, on the verified demographics. That's part, I think that also gets wrapped up in that local match rule issue. Next slide, please. Again, only validated information is allowed to be provided, as I just said. So while you have all these additional demographics that may be required as part of identity proofing as part of the credentialing process, it's only the verified demographics that get submitted in order to trigger the, in order to try to facilitate the match. Again, as I mentioned earlier, the local match rules can be followed. So this is definitely an issue that we can spend a little bit more time talking about, because it's potentially an obstacle to ease of access for individual access through these networks, because there definitely are some hitch points associated with whether there are sufficient demographics that are verified that can actually facilitate a match. Next slide, please. Okay, the data sharing framework also in its policies and procedures includes a requirement to share data with patients where it is permitted by applicable law. The signatories to the data sharing framework are required to provide bi-directional access to health and social services information to a patient or a patient's personal representative upon request. This is very different because it's not just a one-way transaction to the patient. There is this sort of concept of, well, the patient has some information that's coming back, which kind of takes it a step further, arguably, than the TEFCA. And then if a signatory actually has information about that individual, they also must allow the individual to add self-reported information to the record, and signatories are required to maintain a process to correct inaccurate information or resolve discrepancies. And they have to provide an electronic means to be able to assert these rights. In many ways, these expectations are quite consistent with HIPAA. And yet, as Deanne pointed out, there's a lot of participants in the data sharing framework who are not necessarily HIPAA covered entities. So it's going to be very new to them to consider, how do we deal with individuals asking for corrections to their information? How do we provide an electronic means for people to assert those rights, et cetera? Next slide, please. There's more to this. There's quite a bit in this policy and procedure that is quite favorable to patients. If you are a provider or a signatory who's gotten a request for an individual's information, and you don't have the information about that individual, but you know where it is, you actually have to tell the individual or the individual's personal representative who's acting on the individual's behalf where they should direct the request. This is not in TEFCA. This is in the California Data Sharing Framework policies and procedures. Did I just lose my slides? Yes, thank you. Again, there is a requirement to authenticate consistent with the HIPAA security rule, but it's not necessarily at the NIST level 2 requirement, which is the requirement under TEFCA. And the response is required, again, where it's permitted by law, whether it's prompted by the individual herself or maybe by another data sharing framework participant who's helping the individual or acting on the individual's request. So you can see conceptually that this might work where signatories to the data sharing framework say, not only will we will process individual access requests on behalf of an individual, so that the individual doesn't necessarily have to try to hire an app or engage an app to launch those queries herself. I think maybe a situation that might be covered by that. And this policy and procedure went into effect January 31st, 2024. So we should be able to be doing this right now, in theory. Next slide, please. I think that's it for me. Yeah, and it is. Thank you.
Thank you very much, Devin. Appreciate it. One thing I can say, it looks like the work is cut out for the vendor community, with regards to what is possible for them to do, and certainly an opportunity to engage in the development process, and build something of value.
While Eugene pulls those slides up, so I'm Michael Marchand. I'm the Director for Interoperability and Innovation at UC Davis Health, and I've been working in this space for a while. I like to affectionately say I've worked at Sutter, I've worked at Davis, I've been a Kaiser member. So in the last part of my career, I just need to work with Adventist and Dignity or Common Spirit, and I'll have covered every health system in and around Sacramento. So today I'm here to talk to you about really the challenge on the provider side of connecting to all the different frameworks, complying with all the regulations. If you just go to the first slide, Eugene, and I affectionately call it the acronym alphabet soup. So, when you look at the things that providers need to deal with today, and the interoperability frameworks and the ability to protect patient privacy, HIPAA, RCE, IHE, QHIN, QHIO, FHIR API. I think we're all dealing with all of these different acronyms and trying to understand what is our role, what do we need to do, what's required and by when and to who, and to, we don't want to be accused as a provider organization of information blocking. From my perspective as the interoperability person, we are proposing and pushing forward with as much interoperability as possible through national networks, through individual connections with organizations. We're actively participating in working through the sandbox with DXF to try to make sure people can even test their ability to participate. And again, it becomes confusing, but I think that the idea here is that we want to make data available when and where it's needed and to whom it's needed appropriately with the right security and identity. And I think that becomes more difficult because organizationally, we're exchanging millions of records and millions of pieces of information about individual patients locally and nationally on a daily basis. But it's somewhat invisible because if you're a doctor or if you're a specialist or if you're a patient that's looking for information from a particular provider and you're going to a different doctor, how does that doctor know where you went, what information you need, and is it actually a reasonable technical lift, which is in place, or operational lift to get that information where you want it? And I think those are the challenges that we're trying to overcome with all the implementing networks nationally as well as the DXF in California to try to really get the right information to the right person at the right time for the right use. Next slide. So here are all the options. Now the ones on the left, or the phone, mail, email, fax. I think some of those are more or less prevalent today. Part of the challenge with those is that they're non-discrete. They're, especially the phone and email, are even difficult to store electronically. Obviously, I think even at UC Davis, for patients being referred into our organization, we get hundreds of faxes a week for referrals to our specialists. So we're still dealing with this, but I think that what we're trying to do is get data more, I call it data liquidity, is data in systems and available so that it can participate in that exchange. A fax is an image. Obviously, a piece of paper may get scanned or an email may get attached, but those aren't interchangeable from systems. So we're trying to move away in the ecosystem of participants in this exchange framework to a more electronic version. And that's the ones across the top that are that we have today. Direct messaging is if you have a HISP or if you have a certified EHR, that's a way today that we collect and exchange information on a push methodology. So if you want to send information from one provider to another, direct is a great mechanism, a secure mechanism to do that today. And again, if you know the who's and the where's to do that. eHealth Exchange did have a lot of space in my little circles there at the top, but eHealth Exchange came out of the new HIN, the national network back in the early 2000s, 2005, maybe 2009. And they're participating in as a QHIN as well, but they facilitate exchange with some of the federal payers. Our early implementations were with Social Security, the VA, DOD, as they got connected, and now they're participating in larger base exchange, the Commonwealth Network, Care Quality, and local HIEs. And really, the HIEs are super important in connecting that last mile. Not everybody has the technical staff or the ability to connect into those national networks, which is what we've done at Davis and a lot of organizations have done. But your local HIE can be that conduit for smaller organizations that are looking for a way to enter that. And again, as we move to the right of the screen, I think people are hearing a lot about FHIR APIs, which are discrete data interoperability, essentially standard produced by HL7 that allows that discrete data exchange. But we've also got the California kind of the networks, as Dan spoke about and Stephen spoke about, TEFCA, QHINs, and DXF QHIOs that are also facilitating the participation in that exchange and the ability to actually get people the information where they want it to be when they need it to be. And again, those are the future forward. I think that as we implement those frameworks and networks and build those connections and expand the use case, a lot of the current use cases around treatment, but operational use cases, payment use cases, obviously with the pandemic, public health use cases, which weren't fully implemented at the time, it made that data exchange more challenging. I think those sorts of things will allow, and we did talk about individual access services, so patients being able to access their data. All of these things are moving that forward so that all those organizations that you see in the middle of the slide that participate in the care of individuals in our communities have access again to that right information at the right time. Next slide. And I think that's why that last slide is why it's confusing. There are a lot of options, and how do you as a provider know which one to use, what's required, when do you use it? Is the method, are we getting information back? Is there value? Some of the networks require reciprocity, which means basically if you're getting information from the network, you have to be able to publish information to the network. Most of those today, again, are around treatment use cases, but again, with TEFCA and some of the other pieces that we're implementing with DXF, expanding those use cases to other ways to exchange information, and then really specifically defining those methods. So it doesn't turn into 20 different options. There's one or two options that make the most sense. That data liquidity, the path of least resistance, really provides the ability for organizations to exchange information. And really that is the future. I think the federal government is on board. So the ONC has the regulation, the TEFCA regulation. They're aligning with CMS and HHS. And again, the alphabet soup of government regulation or government entities that are looking to exchange information or get information from us. They're aligning under these policies and these networks and these exchange standards to be able to do that exchange. And I really think that that's the big piece here moving forward, is that as we adopt these standards, as we implement these networks and frameworks, the ability for us to exchange data in a meaningful way gets easier for everyone participating. But again, the rising tide raises all boats, but that means we all have to be in a boat. If you're not in the boat, you're not going to be able to participate. And so, whether you're in a cruise ship or the SS Minnow, hopefully you don't get stranded like Gilligan, but you can get on a boat, you can rise with the tide for everybody else doing health information exchange. I think these technologies and these frameworks, if you don't understand how they work or are looking for more information, there is plenty of information and lots of organizations that are looking to help you. And I think that's the piece that I would encourage provider organizations is to really engage and understand where we're headed. I think that's it for me, Eugene. Yeah, sorry. I see we're short on time, but again, I think
That's okay.
I probably just summarized this slide in the last session. I probably should have said move forward, but again, understand how your technology works. What are your opportunities to participate? What are your costs? We can wrap it up because we got 8 minutes. So I was trying to be quick. Got ahead of myself.
You're fine. And thank you very much, Michael. I appreciate it. So thank you all for your presentations. We have a few minutes. We can go over a few minutes if we have to with some Q&A. My question, I think, to all of you briefly is, so this network, this framework is expanding. There's anticipation of hopefully growth of the propagation of the usage, the transaction processing, the type of data exchange between the, and feel free to comment, between the vendors, the providers, the regulators. is there a capacity or thought about tracking and any methodology with respect to volume, with respect to type of data exchange, monitoring of sorts that can be shared with the community? Because obviously, not to sound too trivial, but if you can't measure something, you don't know whether you're moving in the right direction. So maybe if you can, a few words about that.
I'll say I'm
Well,
very
I'll
bad
just
at
speak to-
multitasking. Who
Sorry.
was that?
Michael? Michael, I think we're losing your.
Yeah, so you
There we, oh,
one of the things, yeah, one of the things that's published through care.
Michael, we have to. It was working so well until now. Michael, unfortunately, we can't hear you. So maybe if anybody.
I'll drop the video. Nobody needs to see my beautiful face. The one place, so there are
No, sir. Unfortunately, the video dropping didn't work either.
I actually needed to hear the question again, Eugene, because I was trying to multitask and answer somebody else's question, and I missed your question.
No worries, no worries. So, yeah, the question was, is there a monitoring framework that allows to see, or allows to capture the growth, the volume, the type of data exchange, the quality of the data exchange, something that would allow both the industry, the participants, to see how effective and efficient is the framework that we're using?
CDII is working on impact measurement and coming up with some metrics, but it's going to be a long road. Like, we will not be able to truly see the impact of data exchange framework until over time, but we are definitely have begun and began in 2023 working towards that.
And I'll just add that metrics and measurement regarding interoperability have been a long-standing challenge in all of the existing networks and frameworks. TEFCA is also developing, a set of metrics within the care quality framework, that many of us are involved in. We've seen progressive increases in exchange. I mean, billions of documents being exchanged monthly, on the existing framework. So there are examples of useful metrics that have been monitored over time. But I think for both DXF and TEFCA, we're sort of reinventing the wheel, trying to figure out just what are the appropriate metrics to be shared.
Okay, thank you. So in fairness to the public, we need to have some questions from the public here.
There have been some great questions in the chat, and
yes,
a number of us have been working hard to try to answer them. So,
well,
and also Michael pointed folks to care quality for reporting of that shows metrics on volumes.
Thank you. Yep, indeed. So, question from an anonymous attendee as it relates to IAS, TEFCA, and California are out of sync, correct? With regards to the, I guess the description of IAS.
I mean, both Deb and I have weighed in on that one. I mean, I think they do take a slightly different approach to IAS, each having different kinds of requirements and standards. I mean, my hope certainly is that there will be an alignment over time, and that everyone in California who is now legally obligated to respond to IAS queries under the DXF will do so. We've certainly seen under TEFCA where it's more voluntary, a slow uptake of this. but my understanding, and Devin, you haven't been in some of the meetings that I've been in with Deanne, is that so far within DXF, the approach that's being taken is that it's just an acknowledgement of people's responsibility under information blocking. If they hold data to release it, that there's not a significant effort to federate those queries out across the data exchange participants so that an individual could make one query through, say, Citizen
Right.
or another IAS vendor and collect all their information. They have to go out individually and ask every data holder for their data, which they already have the right to do even before data exchange framework under the information blocking rules.
Well, or hire an app that'll do all that legwork for them, right? To make all those connections. I actually don't think the requirements are all that different, at least where you consider HIPAA covered entities to be concerned. There are places where the data sharing framework takes a step closer in terms of the bi-directional exchange and telling people, we don't have your data, but we happen to know that hospital down the street does. So you can go get it there. They don't have to go retrieve it for the patient, but that doesn't happen under TEFCA either. So the big difference is with the social services organizations, frankly, who don't have HIPAA obligations to respond to users, to patients, to clients, and they're going to have to start doing that, at least to the extent that the law permits them to do that. There's no law changes going on here. There's been, sort of lots of questions about whether there's now an expectation that people share data without consent of the patient. No, if the law requires consent of the patient, you don't share it unless you have the consent of the patient. So there's not really any distinction there. So I think if you really drill into it, there's a couple of additional expectations in DXF, and it's a brand new set of expectations for most social service organizations, but it isn't actually all that different for HIPAA covered entities under either framework.
Thank you. Thank you. So one of the questions was, could you please provide an example of a data exchange transaction that has been enabled by DXF, demonstrated by one of the participants who was required to go by live in January? I don't know if Deanne, if you want to tackle that.
I gave a written example, but I
Okay.
realized some folks might not have eyes on the Q&A. So one example was I looked up Zuckerberg General Hospital in San Francisco. So I looked them up in CDII's participant directory. The perfect world is that a machine is doing this, but it is human readable. So I looked up Zuckerberg. So another participant, say a primary care provider, could see, who has signed the data sharing agreement, could see that Zuckerberg cites care quality and serving communities HIO as their intermediary for how Zuckerberg has chosen to send ADT notifications if requested. So that DSA signatory would then be able to go to SCIO, SCHIO, make a request for notifications from Zuckerberg. So that, just like Devin said about IAS, should be viable today.
I think one of the questions, and probably we're going to be wrapping up here pretty soon because we're a little bit over time, but one of the questions is opting out for the patients out of the exchange, so that if they don't want to have their data shared, they have an opportunity to do that. Maybe can you comment on that within sort of the parameters of TEFCA and DXF, and from the technical viability of this?
It's
I mean,
certainly allowed. Go ahead, Dr.
I can
Rose.
just hazard that, opting out of data exchange is typically done at the level of the data holder. So if you have data at a particular provider, social service, payer, organization, you tell them, I don't want you sharing this with others. Once the data is shared, we really don't have great methods in broad use today to say, this is data that we're sharing, but there's an opt-out associated with it. I only want this data to be used in certain ways or by certain individuals. That's something that we're working on. There's some question answers that were put in related to that. The idea of segmenting and differentially managing data as it moves across the ecosystem is certainly the direction we all want to go in. But today, for the most part, opting out occurs at the data source, the data holder.
And I'll also add that there are some use cases supported in both or subject to be supported or soon to be supported in TEFCA and or the DXF for which the patient doesn't opt out. Keep in mind, opting out of exchange, because this is not putting everybody's data into a giant repository, is not about, in some cases, just you can't do it. It's like saying, oh, I get to get my care completely in secret and no one will ever know about it, even though the entity where you got care may need it to make sure that they're delivering care safely and with quality, or they may need it to be paid. You can say maybe you pay out of pocket. There's some rules around that. They've got public health reporting obligations. So I think we need to keep in mind that exchange is about the sharing of data for a whole host of purposes for which the law, in many cases, has already said you are allowed to share it. To me, it's a different set of questions than, oh, I'm going to stick your data into some big repository that then there are subsequent uses of your data that can be made. I can see where people should be able to opt out of that. But we've had these conversations numerous times from a policy standpoint. When should people be allowed to consent? And when do we honor people's requests for restrictions? There's a whole host of places where that is the case, and a growing number of them given the Dobbs decision and laws here in California and potentially more laws at the federal level to deal with that. We do need to be responsive to those. We need to be responsive to patient concerns. On the other hand, I don't think we can tell people you can just opt out of TEFCA, the whole thing. You can just opt out of having your data shared in accordance with a set of policies and procedures under DXF. That's not on the table.
Understand. So clearly there are more questions and an opportunity for us to talk about them and have a discussion. What I'd like to do in wrapping up is ask you, we're clearly just 90 days after the launch. It's still hot and a lot of data needs to be sort of understood and kind of the trends analyzed. If you were to identify one subject going forward in the next 6 months, if we were to gather together for another webinar, in your opinion, what that subject would have to be, or think about that and something for the record so we can maybe get together at a later date. Please, maybe Devin, start with you.
I'm sorry, I was starting to answer a question online. Can you repeat that?
Yeah. So do you have a subject, if we were to get together in like 120 days from now, in the context of developing of the TEFCA rollout, what would be a subject for another webinar, another sort of, in your opinion, follow-up?
Accountability.
On behalf of?
Accountability of the entities participating in these networks. We have a set of rules and procedures that people are supposed to be following around what are the purposes for which they can query data. Are they saying the right, are they being accurate in how they're querying data? Are they being transparent with people about whether they're keeping that data and for how long and for what other purposes are they putting it to? Whether that's intermediaries in the middle of that or endpoints. I think we have a lot, we're trying to make a more robust environment. Data is going to move around in ways that it wasn't moving around previously, which is mostly good, but does have some downsides. And we need to be able to hold folks accountable for not playing by the rules.
Perfect. Dr. Lane?
I would say that if we came back in 90 or 120 days, it would be great to revisit individual access services, see how those are evolving in both the DXF and the TEFCA frameworks. I think, it should be an active space over the course of this year, and it'd be worth another visit.
Perfect. Deanne, anything from you?
I would say landscape and use cases. So the landscape of where the data exchange framework with Patience and Grace incorporated, because we are still, we have a drive on the required signatories and building a QHIO program, but those are opportunities for being able to paint the picture of where exchange under the framework is standing. So thank you.
All right. Michael, hopefully we got a better connection from you.
We want to try now.
that better?
No, no. You're out of luck
Guess
today,
the
my
guess the
friend.
Wi-Fi in my house.
No.
I'll speak for Michael. Maybe his alphabet soup is sending him written words, clarity in the acronyms for the day-to-day use in his as at the provider level.
Well, folks, listen, thank you very much for everybody who connected today. Thank you, dear speakers and the participants today. I know we had a couple of hiccups here and there, but overall, great presentations. Again, hopefully in a few months, we'll be able to come back and revisit where TEFCA, DXF, and the whole propagation of the solutions are out there. Definitely a hot subject for everybody. And on this, thank you very much, and looking forward to connecting. We will have a recording of this on YouTube for those of you who would want to revisit some of the points here. Thank you.